Welcome to the committee, Representative Ween. Let's see, which bill is this one right here? I'll move your bill for you. I'm going to move House File 90 as 1340 for re-referral to the Health and Human Services Policy Amendment. Do you have an amendment for this bill?
Yes, Mr. Chair.
Thank you. Please proceed.
Thank you, Mr. Chair. Committee members, I appreciate you hearing this bill today, House File 1340. And just a little bit of a background on this bill. The first mental health and substance use disorder parity bill was passed in '96, and a second bill was passed in 2008, which substantially strengthened the mental health parity standards. The regulations went into effect on January 13, 2014. Mental health parity has consistently been a bipartisan issue, with Congressman Ramstad and Senator Wellstone, both serving as key advocates at the federal level. The law and accompanying federal regulations require health plans to cover mental health and substance use disorders as they do for physical health care if the plan covers mental health or substance use disorder treatment. Minnesota law incorporates the federal mental health parity requirements. There are three components of the mental health and substance use disorder parity law: out-of-pocket costs, arbitrary treatment limits, and non-quantitative treatment limits. Health plans cannot have higher out-of-pocket costs for mental health care or substance use disorder than other forms of health care. This means that, with a few exceptions, copays for mental health care or substance use disorder cannot be higher than for physical health care, and there cannot be different deductibles or out-of-pocket maximums for mental health care and substance use disorder. Health plans cannot set arbitrary treatment limits for mental health care. For example, a health plan cannot offer unlimited primary care appointments, but only 3 mental health therapy appointments. Non-quantitative treatment limits are tools a health plan uses to manage their benefit set. Mental health parity stipulates that the standards that a health plan uses to determine the benefits for mental health and substance use disorder treatment cannot be any more stringent or restrictive than it is for other categories of health care. For example, many plans cover rehab in a nursing home after hip replacement, but would not cover rehab in an intensive residential treatment program, or an IRTS, for someone with a serious mental illness leaving the hospital. This would be a mental health parity violation. Other examples of mental health parity violations through the use of NQTLs, which again are non-quantitative treatment limits, include narrower networks for mental health and substance use disorder, using a more stringent process to approve new treatments for mental health or substance use disorder, or more restrictive use of prior authorization requirements to obtain treatment. To ensure compliance with federal parity regulations, health plans must already document the strategies and processes that led to the determination of a NQTL for both mental health and other forms of health treatment. Now, there are grave consequences for patients and families for failing to meet the mental health parity. Some of these include unique burdens, such as having to call to get permission for mental health care, but not other types of care, restrictive drug formularies that make it harder to access necessary medications, higher copays, deductibles, and coinsurance rates that deter accessing mental health treatment, denials of care due to an arbitrary standard of what is deemed medical necessity, limiting in-network mental health providers, making it more difficult to receive care, and lack of coverage for residential treatment or intensive home care. If current mental health parity laws are enforced, more Minnesotans will be able to access the mental health and substance use disorder treatment they need, and the outcomes will be more positive in the long run. In late 2017, NAMI National released its third nationwide parity report called "The Doctor Is Out." The report found that despite the federal parity law, people lack the same access to mental health providers as they have for other medical providers. For example, 34% with private insurance had difficulty finding a mental health therapist, compared to only 13% reporting difficulty finding a medical specialist. And when people did find a mental health provider, many were forced to go out of network and, by extension, pay higher out-of-pocket costs. This happened at much higher rates than when seeking primary or even specialty medical care. 28% receiving mental health therapy used an out-of-network therapist, compared to only 7% needing to use out-of-network medical specialist. A report from Milliman that same year also found higher use of out-of-network providers for mental health and substance use disorder treatment, and a pattern of stark differences in payment rates for mental health providers across 50 states, 3 years and 42 million lives. And at this time, Mr. Chair, I can speak to the amendment. The A19-0126 author's amendment would change the title of the bill and delete Section 1 and 2 of the bill, which eliminates redundant language in consideration of existing federal law, and the language in Section 3 of the bill for NQTLs, which again are non-quantitative treatment limits. The amendment also changes Section 4 of the bill as follows. It allows the Commissioner of Commerce to require data from health plans that mental health parity is being followed. It ensures that mental health care is considered primary care for the purposes of patient cost-sharing requirements, and requires the Commissioner of Commerce, in consultation with the Commissioner of Health, to report to the legislature annually beginning January 1, 2021 on state enforcement of mental health parity laws, rather than mandating this reporting from the health plans. We can now take up the amendment, Mr. Chair, if you like.
I try to lean towards the author, so if you're ready to get the bill in the order that you would like it with your amendment.
Yes,
Do you only have one?
I only have one, yes.
And that would be the 0126?
0126, yes, Mr. Chair.
I don't have to worry about that one, do I? No. All right, then get rid of it. I will move the A19-0126. And you've explained that particular amendment. Are there any questions on the amendment? Any questions on the amendment? Any testimony to the amendment? Seeing none, all those in favor of the A19 amendment, the author's amendment, signify by saying aye. 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 Opposed, same sign. The bill is in the way that you like.
All right. Thank you, Mr. Chair, committee members. And now to speak to the bill, despite federal and state law, mental health parity is still not being enforced because we rely on consumer complaints to identify parity violations. No one in the midst of a mental health crisis thinks to call the Department of Commerce or the U.S. Department of Labor. We need to strengthen the ability of the Departments of Health and Commerce to enforce current law. And just to speak to the bill here, it defines NQTLs, which again are non-quantitative treatment limits, mirroring the definition in federal law and federal regulations. States that a health plan may not impose an NQTL with respect to mental health or substance use disorder treatment if the processes for determining this NQTL are more restrictive or stringent than those applied to medical or surgical benefits. It provides more accountability by giving the Department of Commerce and Health the authority to request the information from health plans to confirm that mental health parity is being fully implemented. This includes any data on the use of NQTLs like prior authorizations, network adequacy, provider credentialing and reimbursement, medical necessity, adoption of coverage for new treatments, wait times, drug formularies, out-of-pocket costs, claim denials, in-home services, rehabilitative services, and other data that may indicate a parity violation. It requires therapy visits and medication maintenance be considered primary care for the purposes of copays and deductibles that a plan enrollee must pay. It requires the Department of Commerce and the Department of Health to monitor the implementation of mental health parity to ensure that that healthcare plans are following mental health parity requirements. This can include market conduct examinations, and it requires an annual report by the Commissioner of Commerce to the legislature every year regarding their efforts to enforce parity law, including any enforcement actions taken. Again, increasing transparency and creating new enforcement mechanisms will lead to better and more long-term health care for Minnesotans and more equitable health care for all Minnesotans. Mr. Chair, committee members, at this time I can stand for questions, or we can allow testifiers to make comments.
Why don't we go to your testifiers, and then we'll, if anyone cares to speak for or against the bill and from the public, we'll bring them down also. Please identify yourself for the tape and proceed.
Thank you, Mr. Chairman. Members, Sue Abderholden, Executive Director of NAMI Minnesota, National Alliance on Mental Illness. You know, we finally begun to understand that our head is connected to the rest of our body and that good mental health is essential to overall health. 1 in 5 people will develop a mental illness during their lifetime, and that's a significant portion of the population. And yet a significant portion cannot obtain the treatment they need to get better. Parity doesn't even require coverage of mental health and substance use disorder. It just says if you do, then you need to treat it the same way. So you have to cover illnesses of the brain, such as depression or addiction, no more restrictively than illnesses of the body, such as diabetes. And parity really, all it really is about is, again, treating mental illness as any other healthcare condition. So the process that you use to determine new medications or treatments should be covered the same way. The drug formulary shouldn't be more restrictive. The in-network list of providers shouldn't be more limited. Plans shouldn't review mental health treatment more frequently to determine medical necessity. Plans shouldn't have more restrictive criteria to determine what is medically necessary. And this federal law, incorporated into Minnesota law, provided us with hope. Hope that we or our loved ones would have coverage for the treatment needed to recover. But I can tell you that the promise of parity has not been realized. My own family was impacted when our health plan wouldn't pay for the emergency room visit or the ambulance because it was a suicide attempt. There was a lesser percentage paid for the hospital bill and a very limited number of therapy visits. To say that my health plan discriminated against covering mental health treatment is an understatement. Many families like mine go into deep debt to pay for the care our loved ones need. Let me assure you, there are no bake sales or GoFundMe pages for mental health care. It's emptying our savings, charging treatment on credit cards, delaying retirement, and more. And it's not fair. We have a crisis in our state with an increasing number of people dying by suicide and an increasing number of people dying by opioid overdoses and an increase in the prevalence of mental illness in children. If private insurance does not come to the table and follow the parity law, we will not stem these crises and it will continue to get worse. Enforcing parity will save lives and state funding. Right now, when parity isn't enforced, people sign up for Medicaid. It's a cost shift. And the care is more expensive because care is delayed and denied until it reaches a crisis. Have you tried to see a psychiatrist or therapist, get into a hospital or residential treatment? You get to wait. And it's not just because there's a shortage of providers. It's because of narrow networks and low payment rates. There are providers wanting to be accepted into these networks because they know there are waiting lists, and the waiting lists are long and told, we're good, we have enough providers. Around the country, states and national organizations are looking at best practices for parity enforcement. All agree that prospective compliance verifications are necessary as long as there's also a retrospective review following a consumer complaint. We need to ensure ahead of time that plans are in fact following the law, and they need to provide information to verify that they are following the law. Now, the plans will tell you there have been few complaints, but again, when you're in the midst of a mental health crisis and the treatment your loved one needs won't be covered by insurance, you don't stop and think, I'll call the Department of Commerce, said no one ever. You shouldn't have to rely on complaints for enforcement. The department should review the plans ahead of time to make sure they are following the law. Last year, we agreed again for the second time to a task force to figure out how the plans would submit data. I want to say that initially it was a much greater analysis that was worked on by the National Parity Coalition that some states have adopted. So it was a huge spreadsheet that they would have to do and quite complicated. And we tried actually over 2 summers to say, well, what information could you provide? And we didn't get anything. And I'm going to be honest, we've waited a decade for enforcement, and we're not ready to wait any longer. The plans tell us that they are following parity. This means that they did their own analysis. We'll show the department that analysis. The data we placed in the bill, instead of the huge analysis, is data that they have. And it's data that will help the departments know if, in fact, they are following parity and treating mental health and substance use disorders the same as other healthcare conditions. Please provide the tools to the department to enforce existing law. Don't place the burden on people struggling with their mental illnesses or on families stretched to the max as they try to navigate the mental health system and the complexity of health plans. Our state got an F for parity enforcement, an F. We're not asking for new mandates. We're not asking for new coverage. All we're asking for is fairness. We just want the current law enforced. Thank you.
Thank you. Thank you for your testimony. I suspect you have another testifier, and it's my regret, or my failure is to have kept you to 2 minutes, so I'm going to try to keep you to 2 minutes, sir.
Thank you, Mr. Chair and members of the committee. My name is Jeff Christensen. I've lived in Lakeville for 16 years. I'm here today to speak about my son, Drew. Drew was diagnosed with bipolar II in the summer of 2014, after he had completed his third year of studies in chemistry at the University of Minnesota. He took his lithium because it was element number 3 on the periodic table. He was studying to be a chemist. He understood what it did. But over time, his swings became more pronounced, making it a struggle for him to perform in his classes. He did finally receive his diploma after completing his studies in the spring of 2016, and soon after that, he landed a job as a contractor at 3M. In 2015, my wife Nancy and I attended a NAMI family-to-family course on mental illness. We learned a great deal about diagnoses and treatments, and we also learned about a community mental health organization in St. Paul called Guild Incorporated. I remember telling Nancy that I wish I had known about Guild when Drew was first diagnosed, because they offered care coordination, which assesses the kind of care someone needs and how to help them, and they had a range of services, including residential treatment. My wife and I longed for Drew to agree to therapy in addition to his meds and quarterly visits to the psychiatrist. He resisted, and there was no way that we could force this athletic and sometimes hot-tempered young man to go. His job at 3M lasted only a couple of months due to an outburst with his supervisor. I had hoped this would be the natural consequence that would persuade Drew to seek counseling, but he landed an even better job right away, assisting with research at Ecolab. He was a contractor again, but this time, this was a dream job with a path to full-time position. We don't know for sure, but we suspect that Drew stopped taking his meds once he landed his position at Ecolab. He was living at home with us during the summer of 2016, and his behavior became more erratic. He was using alcohol and marijuana to self-medicate. He got a DUI in early August and became threatening. Nancy and I had already been meeting with a social worker from Guild on a private pay basis because we needed someone to help us make a plan. We didn't know how to navigate the system to get the help that Drew needed. On September 11th, Drew became threatening again, and we asked the Lakeville Police to help us. He was taken by ambulance to HCMC, where he spent about 10 days. We had insurance through my wife's company, and it paid the majority of Drew's hospitalization and about 50% of the $5,000 ambulance ride to the hospital. After his discharge, he returned home and discovered that he had lost his dream job. About a week later, he was hospitalized again, and this time was prescribed an additional medication to help suppress psychotic episodes. We knew he needed more services, maybe even residential, but it didn't appear that our insurance covered any of these things other than meds, hospitalization, and therapy, and he needed more. We went to the county to see what services we could get there. I took him to his psychiatry appointment, but the psychiatrist wasn't there that day. Apparently, they had tried to leave a message on Drew's cell phone, but he hadn't set up his voicemail yet before he had gone into the hospital. I took Drew to his first meeting with his therapist, and Drew said that he knew more than the therapist. I took him to the intake meetings at the county, and he started becoming discouraged again because of all the consent forms. He was a 25-year-old living at home with his parents, and these were all triggers that he didn't know how to handle. We had found an attorney who helped Drew get past his DUI, and he even got a provisional driver's license so that he could work catering jobs while trying to find another job in chemistry. He was discouraged because he recognized that he had a lot of work to do to reconcile relationships and pay people back for the expenses they had covered for him following his manic episodes. I often worked from home during this time, and we would go for walks, and that would help ease his anxiety. On Monday, November 7th, I reached out to the social worker at the county because I hadn't heard from her about next steps. She got back to me on the morning of November 8th to let me know that they were still trying to figure out whether Drew might qualify for Social Security disability or Medicaid. Medicaid would have covered the additional services he needed. That afternoon, we received a call from the Lakeville Police. They told us that the Minneapolis police confirmed that our son had died that morning. He had climbed the railing on a bridge. Someone stopped to ask if he was okay. He said no, and then stepped to his death. I honestly don't know what services our son might have benefited from, but I know with certainty that he needed more. My wife and I didn't know how to help him, and we desperately needed someone who could act as a quarterback so that we could return to being parents. When a loved one is diagnosed with a mental illness, you don't know what questions to ask. And yet, you somehow need to develop the expertise to know how to work the system to your loved one's advantage. And then there's HIPAA, a formidable defensive line meant to protect your loved one, except that it's really a roadblock at every turn. If someone has a cancer diagnosis, they typically don't put up a fuss about signing consent forms. But when someone is battling the unpredictability of bipolar, it's a lot harder to gain their consent just so that you can help them get the help that they need. I believe that my son could be alive today if the intensity of services provided by Guild had been available to us under our private insurance. Thank you, Mr. Chair and members of the committee.
Thank you. I and all of us are sorry for your loss. Is there another testifier?
Thank you, Mr. Chairman and members of the committee. My name is Kelly J., and I am the mother of Carter Schmidt. Carter's a brilliant, compassionate, funny 16-year-old that has lived with a mental illness since he was 7. The symptoms began with Carter pulling out 6 of his teeth that were not loose. He picked at his skin so much that the wounds wouldn't heal for months. We sought therapy for him, which began our journey into the mental health system. Over the years, all of his symptoms have escalated because he has not responded to outpatient treatment. And more often than not, he refuses to participate. Many times on the way to treatment, he jumped out of my moving car trying to escape the anxiety of going to therapy. In 6th grade, he had his first suicide attempt and his first hospitalization, which started the cycle we have been on in the years since. Ambulance, hospital, partial hospitalization, and which usually is cut off by the insurance company after 8 to 20 days, and then outpatient treatment, which he refuses. We have been on this cycle for years because Carter refuses outpatient treatment and the insurance company does not want to pay for the level of care that he needs. In November, Carter had a knife and was planning to use it to hurt himself. I was able to get the knife away from him, and while I was on the phone with the 911 operator, Carter removed the screen from our 2nd-story bedroom window and was headfirst out the window trying to jump. I caught him in time. I had to hold his hoodie sweatshirt and the belt loop of his pants to keep him from jumping headfirst out of our window. Carter was sent to the hospital in an ambulance. Per usual, there weren't any adolescent beds in the entire state of Minnesota. So he stayed in the emergency room in a locked concrete room with a bed and a television from Friday until Tuesday. No programming, no therapy. The hospital asked us several times if we just wanted to discharge him because there were no beds available. On Tuesday, he was moved to another hospital and was able to get treatment for 8 days in the hospital before the insurance company decided it was no longer medically necessary. He was stepped down to a partial hospitalization program, and I was very worried it was not a high enough level of care to keep him safe. Over the course of that month, he ran away from the treatment program several times. The last time, the Edina police had to be called to help find him. The police needed to be called several times in our home because he could not regulate his emotions, and he was destructive to property. It was determined that he needed a higher level of care, and residential treatment was recommended. We found a program that was a locked facility and is typically a 3 to 6 month program focused on DBT skills and emotional regulation. With his history of running and refusing treatment, this was the best option for his care. I knew that Carter would refuse this option, so I planned a secured car to be at my home the morning of January 1st to drive him to the residential treatment program because I did not believe I could get him there safe with a history of jumping out of the car. Once Carter learned where he was going, he ran from home without a coat, and it was below zero. We had 5 police cars searching for Carter, and we were eventually able to get him into the secured car and admitted into residential treatment. We had several weeks of Carter not responding to treatment and his symptoms were worsening. On January 23rd in family therapy, he told us he was thinking about suicide all the time and he planned to pretend to be fine, but as soon as he was discharged, he planned to kill himself. He was put on 15-minute checks for the next week to make sure he was safe. A few days later, Carter started removing screws in his windows in his bedroom and started talking about escaping the locked facility. Thank you. The 15-minute checks were extended for 1 more week. Upon learning about the extension, Carter threw his chair at a locked door and began throwing his body at the door to try and break it so he could escape. January 31st, the day after this incident, Carter finally accepted that he was there and began responding to treatment. He told us he knew he needed to be there and he wanted to learn the skills so that he never had to go to a hospital again. He participated in school and therapy and began learning the DBT skills that they were teaching. February 7th, the day after his 2 weeks of 15-minute checks ended, 7 days after he started responding to treatment, we learned the insurance company was doing a review of his treatment and had only approved 4 more days. He was no longer in crisis and they were questioning whether the treatment was medically necessary. I called the patient advocate that works for the insurance company and pleaded with her to have her help us. We finally had a breakthrough and we needed him to be able to complete his program. I told her I feared for his safety and I did not believe I could keep him safe if he was sent home. February 15th, we learned that he was no longer covered by insurance and we needed to come pick him up. It was Friday and President's Day weekend. We did not have any services set up for his aftercare. His father and I decided to private pay for the weekend in the hope of setting up services for Carter when he got home. The insurance company denied our appeal. He was discharged on Tuesday with nothing in place. We are currently 3 weeks out from discharge, and Carter still does not have any aftercare services in place. We keep getting referrals to places that are either not covered by our insurance, have long waiting lists, can't take him because he's too acute, or would require him to be in a regular classroom. Since his discharge, Carter has run away from home twice. The first time it was in the middle of a blizzard and he was wearing shorts and no coat. I followed him down the street in my slippers, also without a coat, while I was on the phone with 911. He ran away again on Sunday, no coat. We are frustrated because he was finally responding to treatment for the first time in 9 years. He was on phase 2 of a 4-phase program. He went from a locked facility with 24/7 staff to our home with no services. He needs a higher level of care, and we are unable to get it to him due to our insurance. We are terrified for his safety. Please support enforcing the parity laws. No family should have to go through what we are going through. Thank you.
Thank you. Thank you. Please identify yourself for the tape and proceed.
Mr. Chair, members of the committee, my name is Dr. Paul Gehring. I'm here today as a past president for the Minnesota Psychiatric Society, representing the almost 500 practicing psychiatrists in the state of Minnesota. I'm here to testify in favor of House File 1340. Both my background as a practicing psychiatrist of 27 years and in my role leading the mental health and addiction service line of Allina Health have informed my passion for the parity issue. Over 10 years ago, the federal government passed a critical piece of legislation named the Mental Health Parity and Addiction Equity Act of 2008, which requires equity and insurance coverage of mental health and substance use disorder care. However, years later, mental health parity is still not a reality. According to the National Milliman Report, and confirmed by many subsequent studies, access to care in Minnesota is not measuring up. This bill requires transparency and accountability on the part of insurers. This is necessary because numerous investigations have found that insurers are frequently out of compliance with the federal parity laws requirement that relate to non-quantitative treatment limit. These include practices such as prior authorization, step care, reimbursement rate setting, and provider network design, to name a few. Virtually every investigation has found problems in these areas. According to Milliman, there are unequal reimbursement rates for psychiatric payment practices. They're 40 to 59% lower for psychiatrists. And this is one of the highest rate disparities in the nation. Comparable services provided in primary care and psychiatry would yield $100 in primary care and $41 to $60 in psychiatry. These long-time funding discrepancies have underfunded our mental health and substance use treatment system and squeezed resources for our patients. Long wait times for initial clinic appointments and gaps in service openings happen all the time, and none of these challenges are new. Imagine similar gaps leading to a wait time of 2 or perhaps 4 weeks for in-network service if you had a kidney stone, or sitting in a hospital bed after a heart attack waiting 2 weeks for a post-acute rehab bed. In medical circumstances, there would be outrage and action. The Minnesota Psychiatric Society strongly supports mandated annual reporting by health plans to our regulating state agencies. Despite federal and state laws, mental health parity is still not being enforced. Information is the first step in starting to address this issue and into achieving better partnership between the state, payers, and providers. We don't have transparent data that tells us how far out of a line we are today. HF1340 is a critical step in figuring that out so we can correct it for the benefit of those we serve. I want to thank Representative Lean for authoring this important legislation, and thank you for the opportunity to provide testimony. I'm available to answer any questions.
Thank you, sir. Matthew Schaefer?
Thank you, Mr. Chair, members of the committee. For the record, my name is Matt Schaefer. I'm the Government Relations Director for Medica, and today speaking on behalf of the Minnesota Council of Health Plans. I can empathize with what the other testifiers are going through. About 6 months before the mental health parity law went into effect, I had the privilege of writing a eulogy for a loved one as well. And frankly, it was the mental illness that took him away from us, and there's a relative that got to find the body, and it's not a fun place to be. Having said that, as we look at the bill in front of us, I want to begin by thanking Representative Lane and NAMI Minnesota for the amendment they brought forward. We believe it's a step in the right direction, and though we still would recommend going with a work group model for carrying out the intent of the bill. To give a little context on the type of coverage or how the law is implemented right now, every health plan in the state of Minnesota is required by law to submit any health insurance products that we wish to offer in Minnesota, as well as the Departments of Commerce and/or Health for review and approval. And through that process, each health plan must sign an attestation that we are offering products that treat medical expenses for a mental illness in the same manner in which we would treat a medical or surgical procedure. In addition to that, we're in regular contact with regulators on a number of matters with respect to health insurance, to include ensuring that we're paying our members' medical bills, whether they're being treated for diabetes or depression. In addition, regulatory authorities have the authority to audit carriers to ensure we're operating in compliance with state and federal laws, and they do use that authority. The recommendation we would go for, though, is in addition to that, we're also waiting for guidance from federal regulators as well in terms of how we should respond to different requests for information. That's a rulemaking process that's still in effect, particularly with how the disclosure laws with ERISA interact with the mental health parity law regulations. That's something that we're hoping we'll get some new guidance on that. In addition, the National Association of Insurance Commissioners, the NAIC, is currently in the process of conducting its work on market conduct examinations for mental health parity, which means we're in the process of figuring out what they're looking for as regulators, and they're in the process of looking at our products and making sure that we're operating in compliance with the law. Instead of setting up a new set of reporting requirements, we would recommend going with a work group format, and one of the reasons for which is for the other states that have already passed this law, in the implementation phase, they've already figured out that they need a work group to figure out how they're going to put together this information in a way that is going to help patients and consumers. So with that concludes my remarks. I'm happy to answer any questions.
Are there any questions for the witnesses? Thank you for your testimony. Representative Lean? Representative Lean, you offered to answer any questions. Are there any questions from the members? Any questions from the members? Representative Davids, you have an amendment?
Thank you, Mr. Chairman. I'd like to move the H1340A1 amendment.
Would you care to explain your amendment?
Yes, thank you, Mr. Chairman. What this amendment does is this goes to what the health plans had talked about, what they would prefer. The bill, the way it is not supported by the health plans. In last year's omnibus bill that was vetoed by the governor, we had agreed to language between the mental health advocates and the plans to set up a working group to move this forward. As the testifier said, this really needs to be done. Now, if the lien bill passes, these are the reporting requirements, right here. Now, how does this help anybody that needs mental health crisis care? I don't know. This is what they have to do. Instead of giving care, they got to be filling out papers. Okay, this is just wrong. This is a very one-sided approach. It's heavy-handed. There's no buy-in. You have to have buy-in. We have to have a working group to put this together so you can come. I'll tell you what, you have a working group put this together. You come to the legislature, and I would guess that there'd be 0 no votes. I think it would pass through 100%. Without my amendment, this bill's going nowhere this year. I mean, that's quite obvious. And so do you want something that passes, that gets the two sides together talking, or do you want to have another feel-good meeting and think you're doing something when you're not? Because that's what's going on
Explaining
here.
your bill, your amendment?
Yes, that's what my amendment does. Okay, so it puts a working group together. We don't use a sledgehammer like this bill does. The plans to the amendment, well, first of all, this bill is not balanced as it is. It's not balanced. It's one-sided. It's heavy-handed. The plans already submit information to Commerce on their filings and need to attest to parity in their DHS contracts. They're already doing it. I think we've seen that the real problem here is the Department of Commerce. We have the laws. We can pass all the laws we want. We can put more laws on the books, and they're not enforcing it. Kelly J. said, please support enforcing the parity laws. Amen. I agree. Dr. Gearing said, mental health parity still not being enforced. The laws are on the books. They're there. Throwing another law, a heavy-handed law, making the health plans go through all this, doesn't help a thing. It doesn't help a thing. The laws are already there. I think we need to talk to the Department of Commerce and say, why aren't you enforcing the laws that are already there? That's my question. Is the laws are there, why aren't they being enforced? That's my question.
Did you want me to bring down the Department of Commerce to answer that particular question?
Yes.
Certainly.
Thank you.
Mr. Chairman, if I might, the original bill required that type of reporting, not as amended.
Why don't we wait till we get this question, and then if you would like to speak.
Mr. Chair, for the record, Peter Brickwoody, Assistant Commissioner at the Commerce Department. Representative Davids, the Commerce and Health Department both share regulatory responsibilities related to enforcing parity statutes here in Minnesota, both the state and federal parity requirements. I don't have a comprehensive list of our activities thus far, although we could put one together for you. But suffice it to say, we have been engaged in this issue, and I think NAMI and the health plans could verify that for you. I think one of the potential concerns with a task force approach would be that we have been engaged on an individual plan-by-plan basis with our colleagues at the health department to have discussions with the plans about what is actually being reported and what analyses the plans are actually doing, which occurs prior to them submitting information to the department during the rate review process. Those conversations have been cordial, they've been productive, and they are ongoing. I think our concern is if you put together a task force, you will not be able to have that level of conversation on an individual plan-by-plan basis because the plans will not be able to speak candidly in front of their competitors about what's actually happening in each individual setting. So I think, Mr. Chairman and Representative Davids, I understand the approach that you are advocating here, and typically, that sort of let's get in a room together and figure out the solution. I agree is oftentimes something that we do around here, but in this particular case, I don't think it would actually be as productive as it would be to pass the underlying bill. And Mr. Chairman, if I might as well, I think one of the things in the delete all amendment that we have found is that there is an opaqueness to this issue.
There's
of,
what?
An opaqueness to this issue of non-quantitative treatment limitations. And so having some additional reporting requirements there based on data that I think the plans are typically already collecting, I think would be helpful to the departments in our analysis of whether or not plans that are filed with the department are meeting the parity requirements as they're being attested to in the filings.
And Representative Davids, if I might, if we pass this bill without your amendment, might the patients actually be on an equal footing with the insurance companies?
Well, Mr. Chairman, they already are.
They
The laws are
They
in
certainly
place.
don't seem to be. When somebody has 6 weeks of sitting at home waiting for, to be denied coverage, no, that doesn't seem like they're on an equal footing, especially when you have a parent who doesn't know what they're really getting themselves into, working against an organization whose whole purpose is to make rules and follow rules. So if the representative from NAMI would like to add to this,
Well,
go right ahead.
Mr. Chairman,
Mr. Chairman, I'd like to
I
speak to
recognize
the
this-
proposed amendment. So one of the reasons we changed our bill this year is because we heard from the plans that they didn't want to do that kind of big paperwork analysis, although it is being done in other states. And so we went back to have just the kind of core pieces of information that they already collect. And I know that some of you are new, and I don't often come to Commerce, but we are known for working out compromises with people. We are known for taking on very deep, difficult issues and figuring out how to move forward. But I'm going to tell you that I've spent 2 summers asking the plan, saying you don't need this legislation to come forward, task force, to really talk about what data you can provide, and they did not do that. And so I'm feeling like we have tried. We have come together with, with language we could work on, but we hear these stories every single day, and we're just not willing to wait any longer. And the data that we're asking for in the amended bill is information that they already have.
Representative David, you would like to speak to what I said?
both,
both.
actually.
Go for it.
Thank you, Mr. Chairman. First of all, this bill is not a compromise. This is not a compromise. When one side is heavy-handedly pushing against another, that is not a compromise. And that's exactly what's happening here. Okay? There's no compromise here. But we need to get back to the question and to the chairman's comments. Current law is not being enforced. Do we have to pass a law that says, oh, we really mean it? We should do this? The law is there. It needs to be enforced. And last year, when this working group was put together, and it was in the final bill that the governor vetoed, that's the approach we need to take. We need to have a balanced approach where both sides have something to say. They both get to say, this is a very heavy-handed, one side. I want everybody to win. We need a win-win, and it's not happening with this bill. And if this amendment doesn't go on, this bill doesn't happen.
Any other questions for the testifiers? Oh, Representative Swazinski.
Thank you, Mr. Chair. Just a kind of a comment to maybe the Commerce Department. It sounds like, your fear or not worry potentially with this is that some of the plans are concerned about their, talking about potential secrets or kind of the way they're going about their business in a public forum, and you feel that some of those, is there a way that you could maybe produce a document that, from a blind side where we're not hearing exactly from which they are, so they can hear their comments, so that maybe that could be part of the solution, assuming Representative David's amendment goes on, or, is there, you feel like, in a public forum, maybe they're not going to be as free to speak, and, what are your thoughts along those lines?
Mr. Chairman and Representative, appreciate the question. And I think that's what we're actually doing right now. I think after the bill that was not enacted into law last year that would have established a similar kind of task force, the departments, Commerce and Health, started to reach out to the plans and have that very dialogue individually. I think we are conscious of not wanting to, violate that regulated entity conversation. And so we haven't broached the topic with plans individually about what do we produce after this, but I think the focus has been how do we improve the rate review process and the network review process that we conduct on an annual basis so that we have better information from the plans to inform whether or not the parity standards are being met, and to utilize the existing system that we have to provide some better window for the regulatory agencies into what's actually happening for consumers. Mr. Chair, I think the task force may not necessarily allow us to have that kind of conversation with plans individually because they will not be able to have the kind of direct conversation that they're able to have when we meet with them one-on-one. So long answer to your question, but Representative, I think we're doing that now.
Any other questions? Any other questions? Any final comments on your amendment, Representative Davids?
No, thank you, Mr. Chairman. I would just say that the argument that Commerce is making is a fallacy, that you have to have private meetings. You can't concurrently have a working group. That's nonsense. I'd appreciate member support.
All those in favor of the A1 amendment signify by saying aye.
Aye.
All those opposed? No. The amendment fails. Back to the original bill as amended, House File 1340. Representative Lean, did you have any final comments?
Thank you, Mr. Chair, committee members. I certainly appreciate the very spirited debate here today. And really, especially, I want to thank the families for coming out and sharing those stories. That's very heartbreaking. I have a good friend who suffers from mental health issues, and so I've also seen his family, go through a lot of these crises and situations. And I would just say, the federal mental health parity law was passed 10 years ago. So we've had 10 years for the policies essentially to figure out how to work this out, how to provide the coverage and everything. And this is not mandating benefits. It's mandating parity in the way processes go in place for coverage. So I don't know that another government directive for them to get together and talk through this is completely necessary. I hadn't really seen the amendment before today. I know the health plans came into my office briefly the other day just to speak about it, but I haven't had real in-depth conversations about how this task force would look or anything. But again, if we're going to take governmental action here to help these families, I don't know that a task force is the best way to do it, to continue to talk about this problem for another year. The health plans have this information. If it was given to the Department of Commerce, the department would better be able to enforce mental health parity. And, just to speak to the issue that this is a one-sided conversation, well, in my mind, for the last 10 years, it has been a one-sided conversation. We have families who are suffering through crises, losing loved ones, not being able to get the help and the services that, quite frankly, they're paying for through health insurance premiums right now. So, members, I just would really appreciate your support on this bill. Thank you.
Seeing no further questions, the chair will renew his motion to re-refer House File 1340 as amended to the HHS Policy Committee. All those in favor signify by saying aye. Aye. Opposed, same sign.
No.
You're on your way.
Thank you, Mr. Chair, committee members.